All right, here is a case study on syphilis. So the patient is a 32-year-old male who presents to a primary care clinic with a complaint of a painless ulcer on his penis, noticed approximately 2 weeks ago. He identifies as a man who has sex with men and reports multiple recent sexual partners. He is HIV negative, sexually active, and inconsistently uses condoms. His sexual history and demographic profile place him at increased risk for sexually transmitted infections, including syphilis, which has shown a rising incidence, particularly among male men who have male sex partners in recent years. The patient reports a single painless ulcer at the base of his penis, which he initially thought was due to friction, but has persisted without improvement. He denies any pain, discharge, or urinary symptoms. On further questioning, he reports mild fatigue and tender swelling in the groin area. These symptoms align with the primary stage of syphilis, classically presenting as a solitary, non-tender cankry accompanied by regional lymphadenopathy. He denies fever, rash, or systemic symptoms, which would suggest progression to possibly secondary syphilis. He has a history of prior chlamydia infection, but has not been diagnosed with syphilis in the past. He admits to inconsistent condom use and frequent new partners, particularly through dating apps, which increases his risk of both acquisition and transmission. He also has not received recent STI screenings and was unaware of the rising prevalence of syphilis among MSM, particularly among those with multiple sex partners or HIV. On physical examination, the patient is afebrile and appears generally well. A solitary indurated non-tender ulcer, approximately 1 centimeter in diameter, is observed on the shaft of the penis with clean edges and no purulent discharge. Bilateral inguinal lymphadenopathy is noted and mildly tender on palpation. No rashes, mucosal lesions, or other systemic signs are present. These are classic signs of primary syphilis and reflect the site of Treponema pallidum inoculation and local replication. Based on all of this, the diagnosis is primary syphilis caused by Treponema pallidum. This diagnosis was based on the hallmark presentation of a painless genital cankry accompanied by regional lymphadenopathy and his epidemiological risk profile. The painless ulcer and absence of systemic symptoms suggests that it's in the early stage of infection and was likely acquired within the past 2 to 3 weeks. This matches the incubation period and initial pathogenesis of syphilis, in which spirochetes replicate locally and trigger an immune response at the site of inoculation. His demographic and behavioral history, particularly being MSM with high partner turnover, further supports the diagnosis. Initial testing includes both non-treponemal and treponemal serological tests, such as a rapid plasma Reagan or RPR, or venereal disease research laboratory test, VDRL, should be ordered first, as these assess disease activity and are used for treatment monitoring. Then this could be followed by a confirmatory treponemal-specific test, such as FTA-ABS or TPPA, which detect antibodies against T. pallidum antigens. In this case, the RPR is expected to be positive with a significant titer, and the treponemal test would confirm the diagnosis. Dark field microscopy or PCR of the lesion could also detect T. pallidum in the ulcer exudate if available. First-line treatment for primary syphilis is a single intramuscular injection of benzathine penicillin G, which is highly effective in early syphilis. For patients allergic to penicillin, alternatives such as doxycycline might be considered. Follow-up serological testing at 6 and 12 months is necessary so that it can be ensured appropriate decline in RPR titers and to assess for reinfection or for treatment failure. Additionally, risk reduction counseling, condom use, and partner notification and treatment are essential components of disease control.